Alrighty, we just have a few on the docket today, so let's just get through them. First up, this one might be the longest one that I talk about, but title: Manual therapy promotes prefrontal neural efficiency in chronic nonspecific neck pain. This is a functional, essentially MRI-based randomized controlled trial where they wanted to see in these patients compared to controls what kind of stood out between standard care, so exercise, and if you added manual therapy to it. So, first up on the docket, both, because they included exercise, showed similar long term benefits in the sense that they had reduced disability from this chronic neck pain. They also both reduced pain. So, if we're looking at it entirely from generic pain for chronic neck pain and generic disability, if you have just enough time to do the exercises and nothing else, no additional, you don't absolutely need the manual therapy. One thing that they did want to highlight, though, is that there was a seemingly unique benefit to adding manual therapy into that care, in that it was the only one between the two that seemed to have some sort of effect on the prefrontal cortex. Now, this is one of those things where if I'm repeating what I just said, do you absolutely need manual therapy? No. However, it does seem like there might be a case, if there's actually nuance when seeing a patient one on one, to maybe encourage that they receive some in their unique case of chronic neck pain. That's really a long winded way to say, if I'm triaging patients appropriately, there will be an individual that isn't just from a time standpoint, that isn't just from a they want manual therapy. It's very much based on their clinical presentation, where I believe that they are developing kinesiophobia and they are developing something either called hyperalgesia or allodynia, which is either a a a brain's the brain highlights or emphasizes the pain above what you'd expect. So take a typical painful stimulus, poke somebody, okay, it hurts a little. To these people, it would hurt a lot. And allodynia is you take something that shouldn't even be painful, like, if I just press and all of a sudden somebody's like, ow, that's allodynia. It's a painful response to something that shouldn't be painful to begin with. So in patients who, during the course of their individual chronic neck pain, have developed something similar to these symptoms or developed those symptoms outright, it may be, this study is not saying this. It's just we have to um, kind of take the next step from this article and try and figure out where it's most clinically applicable. And to me, in my mind, this is where it goes, is that if this restores fronto and frontoparietal, um, they call it network connectivity, but it's really they just see an uptick in the brain scans when people go through this. It may be that somebody who has what's called a centralized or a um, brain heavy condition. No, not condition. They have a, how do I want to explain this succinctly? When their brain is one of the primary drivers to why they're feeling as much pain as they're feeling, it seems to be that they could uniquely benefit or um, benefit more than anybody else in receiving that manual therapy. Now, this was only done on 30 patients, so the groups were small, and there's definitely one of those where you can tell that I want to say this cautiously because I don't believe anybody really needs everything, and like social media will say you either need everything or you need nothing. You either need to go the Spartan minimalist lifestyle, like have nobody take care of you, just hardcore everything, or you need the absolute pampering and you can't do anything right. Like everything else, the answer is always in the middle, guys. So this study to me just shows that there could be a unique time and place to encourage manual therapy because you're dealing with a patient that is in an excess pain to what their condition should um, state they're in, and they don't have any other red flags. There isn't actually anything causing the pain. And this could be a unique way that we open up the space for them to do the exercises that we know are going to be most beneficial for them in the long run, is that we incorporate the manual therapy on top of this so that they don't have, or they are at less of a risk of developing or worsening the fear of movement, and that they're becoming more self-capable because we are adding in this hands-on care to their unique clinical case. I think that's going to be the best way that I can say it succinctly without rambling on for too much longer. All right, 3 more studies. Comparing the effectiveness of physical therapy interventions in adults with rotator cuff tendinopathy, a systematic review. This one was kind of all over the place. Like, yeah, exercise and just exercise is great, but the evidence is sloppy or messy, which they're right. Um, there's also additional treatments with like TENS units, muscle stims, dry needling, and these combined therapeutic approaches. And it didn't really highlight which one or two like really stood out, but it's like, if it seems like if you combine them, it's great. Which, despite the fact that the evidence is, we'll say, sloppy, just it ties into everything else that we've read, as far as you don't have to take an isolated approach to care if there's no red flags, if there's the time, and as long as your provider is emphasizing the fact that exercise, mobility, and self-efficacious activities are the best for you long term. Having the ability to pull in things like electrophoresis, stim, dry needling, taping, strapping, instrument work, even if it's shown not to do what we think it does. Like, I've heard this when I was going through school, instrument work breaks up scar tissue and we're changing the tissue underneath the tool. We are absolutely not. Other studies are like, well, it's just really enhanced placebo. Okay, so if we're able to harness this for the right person at the right time, for the right reasons, with the right narrative and the right education piece, then this is just still a good thing for the patient in front of us. One of the new ones that I saw was, hey, even if we take the tool out, the person being in the room with the provider in and of itself could be the placebo effect. Just by being in the space, trusting you as an expert gives them enough of a, yeah, it's great. Well, then they'll swap in the argument of, well, then that's why you don't need to do manual therapy, because that same effect will happen. It's like, well, maybe the person perceives you to be more of an expert because you're willing to take that time to actually get your hands on the patient. So their placebo wouldn't have triggered until you actually put the hands on, or it wouldn't have been enhanced the way it is. But that's a discussion that I could have with somebody over a cup of coffee and on a podcast, and not something that I need to just bog you guys down for. So suffice to say, this study was just backing up what we've said about with everything else for most other musculoskeletal conditions, in that as long as the person is emphasizing exercise and the things that are really going to keep you better, then during the short-term period when you're trying to take care of pain and other things, by all means, add in safe and ethical interventions for the right person for the right reason, whether that's just hands-on massage-like activities, soft tissue work, instrument-assisted work, dry needling, muscle stim, TENS. Just don't get somebody or a provider who is emphasizing just doing that, charging you in excess, not taking the time to hear you out. Like, we should develop a list of kind of red flags, and as long as they're not hitting any of these red flags, and you're finding the provider that is getting you better and getting you back to the activities that you need to do, then it seems to be all good, specifically with rotator cuff tendinopathy for this study. So next up, I think this one was a bit shorter here. Oh yeah, GERD, so gastroesophageal reflux disease, seems to be at risk, or the patients who have GERD seem to be having a higher risk of developing temporomandibular disorders. And I think if I go down here, it's somewhere in the realm of like 20 to 30% increased odds of developing TMD. Yeah, I'm not going to take the extra time to like scroll through this again, but Last number that I remember seeing on this study was that it's roughly like a 1.4 odds times or a greater chance of developing, which winds up being like 20 to 30%. No, sorry. It was like 1.25 to 1.4, which is like 25 to 40% increased odds of developing TMD. So in this instance, it's like if you have somebody with GI issues that you're suspicious of uh, GERD, or you having a patient, like if a patient comes to me and says, oh yeah, by the way, in my history, I have GERD, and you know what, I'm coming to you because I have headaches. Well, for me, that means, okay, one thing, headaches and TMD are already tied together in a similar fashion, and they have GERD, which is, something in their history that they're telling me, and they're primarily coming to me with headaches, but they haven't told me anything about the jaw. Maybe they either don't think about it, don't have it, or they just haven't felt like telling me. So it's my job now, knowing these things. Hey, GERD has a higher chance of developing TMD. Headaches are associated with TMD. They haven't said anything to me yet. So why don't I now ask the question? Because we see these trends in healthcare. Hey, patient, do you also happen to have any issues with the jaw, such as, pain, clicking, popping, locking, anything like that? Maybe they say, no, I'm all good. Great. Don't have to worry about it. And we can just dial back maybe what we're doing in care versus like, you know what, now that you mention it, it's like, aha, now we might have actually gotten somewhere that can really help this patient because we're starting to tie things together. So that's what these studies are really supposed to do, is just to kind of prime your clinical yellow, orange, and red flags about what to look for, what to ask for, what to screen for, and then how to properly manage patients, because these things aren't always in isolation. If you find one thing, there's a good chance you may find another. Last but not least, this one's kind of straightforward, where I almost just wanted to say, like, well, duh. Um, Spondylolysis and spondylolisthesis is associated with disc degeneration in pediatric patients. Yeah, duh. um, but I guess it's one of those things we need to put pen to paper and actually kind of figure out percentages, which this study did do. So first up, they had a control group where the control group just had abdominal MRIs done for some purpose in this single center study. So what they did was these researchers took a look at who got MRIs across the pediatric age range, which I believe they said had to be under 18. Yep. So they had a mean age in the testing group. So they had 67 patients that they wanted to test that had spondylolysis and or spondylolisthesis, with an age range of about 15, give or take 2 years, and about half were female. They then further split it up on who had just the spondylolysis, spondylolisthesis, etc. And they compared that to people who also went through the center within the same age group, who got an abdominal MRI to look for other GI issues. So they looked at their spine who did not have these, because they're comparing discs. They're not comparing conditions where, if somebody had spondylolisthesis, you get put into the actual study group, versus if you had the clean MRI because you were not giving in for something to monitor, manage, or check spondylolisthesis, you were now the comparison group because you're actually assessing the disc quality or disc health. I'm using air quotes here. So what they found was, and I want to highlight this first, in the control group, which I think were 20 patients. Yeah, 20 patients about the same age, 15 plus or minus 2 years, with again half female. In the control group, where they studied 40 intervertebral discs, there was no degeneration in about 90% of them. There was degeneration in like 8%. So if we're looking at total numbers, 40 discs, 37 were clean, 3 had some form of degeneration. That's in adolescents with healthy spines. So not common by any stretch, but still possible. Now they flipped it and said, all right, now we're going to divide this research group into just spondylolysis, grade 1 spondylolisthesis, and basically 2 to 4. So anything bigger than a grade 1. Now, I suppose before we come to the results, let's just review. A spondylolysis is some sort of defect in the pars region. So I'm going to use medical terminology because it helps my brain orient a bit when I'm talking about this stuff. So when you have, I wish I had my spine here. It'd be easier to do something here. So if we kind of have, let me pull up my camera so I actually get this right here. So if we have the actual disc, so where my knuckles are the bones. In that opening between here where my pointer fingers are, that would be the canal where the cord goes through, and my thumbs would be the pointy bit, the spinous, where you can actually kind of feel on your back that the pokey part that sticks out. So right where now watch my thumbs now. So between my thumb here and here, where you start to go from the body, the thick body, down into the pointy bit, you have the pars and the lamina essentially are just landmarks that you pick on this part where you go from body to pointy bit, and there is usually some sort of a defect in here that you can pick up on x-ray that, if we put it in layman's terms, ranges from like a hairline fracture all the way up to a non-union. So what typically happens and why these come out in a younger population, and especially an active younger population, is because when the bone itself is forming, you have about 3 centers in each vertebral body. Let's just pick one. So let's just say there's a center here, a center no, there'd be one center in the big body itself, and there might be 2 centers on either side, where when you're itty bitty baby, it's mostly cartilage. As you go through puberty, you start to actually develop from a musculoskeletal standpoint, and those cartilage centers start to turn over and get replaced with full-on bone. And there's 2 main different ways this happens, but beyond the point of this video, suffice it to say, they start to grow together, kind of like stalactites and stalagmites. They try and meet up and connect and fully fuse, which is where you get these full bones in an adult. So what happens is during activity, it's kind of like going in a cave and you kind of rub oh, hey, don't do that. You're going to get oil, debris, etc., and you're going to prevent them from continuing to grow together. In many instances, this is the thought process to why we have idiopathic, or nobody knows why, we have adolescent non-union spondylolysis, where those 2 parts don't fully fuse together. And so that's the thought process, is there's just so much repetitive movement that the growth center doesn't get just the breathing room to grow together. But again, I don't want to just say, well, then we should just put all kids in a bubble and not have them no. A lot of the times you don't even know you have it until there's the random x-ray for a random reason. So this is most of the time asymptomatic, and it's rarely something that ever needs legitimate intervention above a conservative level 4, because, again, it's not usually that big of a deal. Okay, I'm just talking through the process of what happens to hopefully give you guys an understanding of what this study is talking about when we get back to it. So we have spondylolysis, where there's some sort of a non-union or hairline fracture or something that you can pick up in an x-ray in that region. And the listhesis part, so you go from lysis to listhesis. Either means that when we take a side view, let me get the camera here. So where one comes on top, there's the space in between here where there's a disc, and then you got the guy on the bottom. I'm just going to stick them together for ease of description. So listhesis means compared to one other segment, one either slips forward or backwards compared to the one above or below, wherever you want to measure it. So it's either a forward slip or a backward slip, and you'll see that on a radiology report. So if you happen to have it, it'll either say antero, slip forward, or retro, slip back. So the umbrella condition, spondylolisthesis, there's some sort of a shift. Antero, oh, it slipped forward. Retro, oh, it slipped back. They grade it based upon how much slippage there is, which is where you get the 1, 2, 3, 4 grading scale. And if we go back to the study now, hopefully this makes more sense. So they wanted to take a look at just the spondylolysis, so they didn't see any slippage. The grade 1 listhesis, so there's just a little slip. And then 2 through 4, there's moderate to, oh dang. And let me break back the numbers. So let me go off of the camera, go back to the results. So compared to the control group, patients with just spondylolysis Grade 1 spondylolisthesis and grade 2 through 4 spondylolisthesis had higher rates of disc degeneration. These rates at the level of pathology for patients were with, oh, they do it respectively. So patients with spondylolysis, about 24% of patients with just spondylolysis had some form of observable disc degeneration that the radiologist could see. If you had the spondylolisthesis, so that grade 1, that gentle slippage, you went up to about a 64% incident rate of, oh, more than half of the people that had that, gentle slippage had some form of recognizable or noticeable disc degeneration. And then once you got through grades 2 through 4, it was everybody. So once you get to that big of a degree, there's disc degeneration. I'm using air quotes, not because they don't have disc degeneration, but anatomically it makes sense. And then I also want to make sure that we highlight a specific point here. It makes sense that if there's a non-union, so, or if there's at least some sort of slippage, that you would have some local changes to the surrounding anatomy to accommodate the change in structure. So if you have that slippage, I've seen some pretty gnarly things with like the high grade 3s and 4s where the body's laying down extra bone to buttress and reinforce the area. So to me, when I looked at this study in kids where it's just like, yeah, if you have the spondies, the spondylolisthesis, there's a really good chance you can have disc degeneration. And I want to highlight that because parents, when they take a kid in, they're playing football, they see that there's a low grade spondy, and a lot of parents will get scared to the point where like, oh my gosh, does my kid need either an immediate back surgery, or do I have to consider putting them into like prep them from a parent to kid education about, man, you're going to need back surgery by the time you're no. I mean, I don't think so, but those are conversations that I run into where parents are scared, like, my gosh, I need to put my kid in a brace now. I need to be concerned about their blue collar job. And I think the biggest thing that parents do to try and help their kid that in the long run actually will probably lead to more harm than good, even if it has great intentions, is having the kid be overly cautious with their movement from here on out, because we are so protective of somebody, especially when it comes to something like the back, because a lot of the times, well, back pain and back conditions are so prevalent in today's society. Any parent would try and do as much as they can to, at least what they feel, prevent the issue. The problem is isolation and non-moving and rest and avoiding things is actually the way that we make it worse, by not actually making it stronger and more capable to handle these things. So yes, if you have these spondies and you're an athlete who's younger, there's a really good chance you're going to have some sort of disc degeneration. But we always have to ask, is it symptomatic? And is it causing other issues? Like disc degeneration, we don't ever call somebody who's over the age of 60 with wrinkles on their face. Like if you see a wrinkly face, like, aha, that is a noticeable sign of skin degeneration. No, it's just wrinkles. And we also know it's a normal part of life. And if somebody has wrinkles or things that we notice like that, not in the anticipated age group, we know that there's another reason, but that another reason doesn't have to be pathological or bad or something we need to avoid. So I don't want this last highlight to put fear into anybody. I just want it to be something where you can expect, like, hey, I know my kid's 15. His back's been hurting for like the better part of 3 weeks. The athletic trainer wants him to get an x-ray because they want to look for some things. If they get a spondy, I don't want anybody to be scared about seeing disc degeneration on there, because it's something that we are primed in a society to pick out from an x-ray study. Just knows like, oh yeah, he's got a spondy. Well, now I know what these kind of are. We know why he's at least in the short term hurting. And oftentimes, it really comes down to, is this a fresh or an old one, that dictates what kind of care they're going to get in the short term. So if it's old, ergo they had this when they're like 14, they're only hurting now when they're in their mid 15s because they increase their activity, that it's hard to gauge in that age group. You don't necessarily just want to brace them up and just tell them to wait. Now, contrast that to something where you know it's a fresh spondy because, all right, the x-ray showed a spondy. Maybe they did something like an MRI and you see some um, inflammatory markers on the MRI that can only happen in the acute terms. Like, okay, so this right now, he's in pain and it is a hot spot. It is currently inflamed. Fine. We have a legitimate reason just to put on the brakes for anywhere from a couple of weeks. I think longest I've seen within reason. Is like 4 to 6 weeks. But then after that, it really comes down to honestly, people are sometimes overly cautious unless there's a factor that I'm not aware of. Because a lot of that inflammation should go out in like 2 to 4 weeks, and then you can add on like an extra two just in case. Um, but if it's an old spondy and if they're hurting, oftentimes it's all the spondy is a factor in their care, not the point of your care in the chronics. If they're the acutes, then by all means, they're the point of the intervention that you're calming it down and then building them a program once it's calmed down to make it stronger afterward. So disc degeneration and spondies, common to almost guaranteed in this small cohort. Don't be scared if you see it on x-ray. And really after that, it just comes down to, is it old or fresh? If it's old, we'll just find strategies around it. If it's new, we'll make sure things are calmed down before we actually get the gas pedal. We put the pedal to the metal and get the kid stronger again. So hopefully I didn't confuse people too much. Hopefully you got something out of this, and I look forward to our continued conversations on here. DM me, reach out, email me if you have any questions, concerns. Until next week.